Great. Hello, everyone. It's great to be with you all this morning to talk about the Chicago and Cook County Flexible Housing Pool, a housing intervention and housing and health intervention targeted to people experiencing homelessness who have complex medical health conditions. Oh, okay. So again, my name is Christine Haley, and I am the Director of Housing for Cook County Health. And I have with me today a colleague from CSH, Julie Nelson. And first, we'll start off by talking a little bit about our organizations. So Cook County Health at a glance is one of the largest public health systems in the health and hospital systems in the US. It includes 2 acute care hospitals, Stroger on the west side of Chicago and Provident on the south side of Chicago. We have 14 community health centers that are based in the community. The Core Center, which provides comprehensive care for people living with HIV and hepatitis. We provide the health services in Cook County Jail. We also include under our umbrella the Cook County Department of Public Health, which serves suburban Cook County as its public health entity. And then our health plan services unit includes our health plan, CountyCare, and we also have a Medicaid Advantage plan. So we've been around for 180 years, and in that, Cook County Health serves about 500,000 people each year through the health system, through our hospitals and clinics and health services, and then also through the health plan. We do about 1 million outpatient visits a year, are able to analyze over 5 million lab tests a year, and prescribe about over 1.5 million outpatient prescriptions, including for folks who do not have health insurance. We screen over 55,000 people who enter Cook County Jail for health needs, and conduct over 46,000 visits to the Core Center. And as of September 25th, 2020, I can update this slide, we had 370,000 CountyCare members, but those numbers have, we've seen increases to our CountyCare membership as the impacts for COVID-19. So let me pass it over to my colleague, Julie, to talk a little bit more about CSH.
Good morning, everybody. So again, I'm Julie Nelson. I'm the Associate Director with the Illinois team at CSH, Corporation for Supportive Housing. So at CSH, we actually are a national organization. We're a not-for-profit, and we work across the country to really support folks in improving lives, maximizing public resources, and really working to use supportive housing as a foundation for strong, healthy communities. So looking at what we actually do, and Christine, you can go to the next slide. We have 4 kind of lines of business across CSH. So the one thing we don't do is we actually are not a supportive housing provider. However, we are a CDFI, which means we do lending. We do lending throughout the United States for supportive housing projects. We also do training and education, sometimes in person, back in the days when we could do in person, and we do a lot of virtual training. And we also actually have a supportive housing training center that's always been web-based. We also do policy reform work, state-based, local, as well as nationally. And then we provide consulting and assistance to communities and TA to really support a community in advancing supportive housing solutions that are unique to their needs.
We wanted to talk a little bit, we'll get into talking about the flexible housing pool and what it does, but just to provide some context for why a health system has invested in the housing and housing initiatives. So first, to talk a little bit about homelessness and why Cook County Health is invested in looking at how to create housing solutions for people experiencing homelessness, and to really think about first if we are trying to understand health disparities and working towards the elimination of racial and ethnic health disparities, what does it look like for us and for the population? So first, and looking at the mortality disparity. In LA County, they do an annual death report looking at a number of factors that cause people to, why people are dying, and really focused on people experiencing homelessness. We are working on trying to get to have a Chicago or Cook County based mortality report. But what we see in LA County is that the average age of death for all residents is 73, but the average age of death for people who are experiencing homelessness is 51. Causes of death, some causes include people who have died from having opioid use disorders, but that's not, and that can drive the age down, but not completely, right? That there are other chronic health conditions that people experiencing homelessness have that also are driving down this average age of death. And so how do we understand this as a community, this disparity, and what are the ways in which we can address it? Another piece to understand is the racial disparities that exist for people experiencing homelessness. And we have data at the county level and at the city level. At the city level, we know that about a third of the residents of the city of Chicago are Black or African American. But that of people experiencing homelessness as individuals is about a quarter, 3/4, so about 75%. And then homeless families, women and children, or parents and children, are about 90% of the population are African American. So that's this disparity. Is known to understand that although racial disparities exist in other parts of the country where African Americans are overrepresented within the population, that this overrepresentation is worse in Chicago than in other big cities. So there's something specific that's happening here as it relates to racial disparities that we need to work on. So as a health system, we completed a data linkage in 2018 in order to prepare for our investment in the flexible housing pool, where we did a match where we looked at our electronic health record and then looked at the homeless management information system, which is the homeless database where anyone who is seeking homeless services comes in. Where there are about 6,000 people who unaccompanied individuals who are in the HMIS database. And of that, we found that about 81% of people in HMIS had a record within the Cook County Health System. And that helped us really concretely understand our role as the largest single provider of healthcare for people experiencing homelessness in Chicago. But that we also understood then that about 20% of folks also, which was part of this, had CountyCare as their health plan. So in that, we understand that we as a health system are part of the solution and both part of the solution in ending homelessness in our city, and that it's important for us to really understand, as we are taking care of people within our health system who are experiencing homelessness, how can we be at the policy table and actually make investments in housing to support our patients and members. So of all of the issues, why do we focus on housing as well? So this is a slide from the Centers for Disease Control that look at what are called social determinants of health. And when we think about what makes us healthy, we understand that about 20% of what makes up making an individual healthy, about 20% of it is clinical care. that is provided by our health system. But the rest are made up of other environments or the other factors. Some call them social risk factors or social determinants of health. So our health behaviors make up about 30%, socioeconomic factors about 40, and then physical environment. Although I will say that, for a person experiencing homelessness, it's difficult to be able to address any of the, health behaviors or maintaining clinical care when you're in survival mode and just trying to figure out where to eat and where to sleep. So for the social determinants of health, we understand that work is part of our work in addressing as a health system, not just the clinical care aspects, but what are the other areas of care that we should invest in. Another piece of background to understand, and this came out of NYU and looking at life expectancy gaps in the United States, that there are concrete links around what it means to live in segregated neighborhoods and how that impacts life expectancy. And in this report, they found that of the 500 largest US cities, 56 have large life expectancy gaps between 20 and 30 years. And that in Chicago, there's the largest life expectancy gap across neighborhoods in the United States. So that 30-year gap was the largest gap nationally. So I think that it's important for us to understand that these gaps, although they exist nationally, that ours is the worst, and that we have, again, a special responsibility to understand the role of segregation and these other impacts on health and longevity. And to say that, that when we look at housing, that all of our housing impacts our health. It's not just those that that my housing impacts my health, your housing impacts your health, that it's really that these are social determinants for all of us. Okay, so we wanted to spend the bulk of today talking about the Chicago and Cook County Flexible Housing Pool. So we've talked a little bit about, housing as a social determinant of health, but in that we've seen from studies that have been done by local healthcare partners that up to half of people who are frequent utilizers of the emergency room are in health systems are experiencing homelessness. That we see a number of people that in addition to experiencing homelessness also have behavioral health conditions, meaning that they have a substance use disorder and or a mental health disorder, such as schizophrenia, depression, anxiety, and other chronic health conditions. There was a study that also was conducted with healthcare partners and University of Illinois at Chicago, University of Illinois Health Systems that looked at with a housing intervention. They saw a 41% reduction of emergency room utilization and also a 52% reduction in inpatient stays. We also see from national studies that when a person is experiencing homelessness, they have longer lengths of stay because of over 2.3 days, longer inpatient stays, which we can think about how if there isn't a safe discharge destination for someone to go to, that it takes longer. If someone isn't able to return to a home, that's harder to discharge. And that then there's higher readmission rates for people experiencing homelessness. And readmission after a hospital stay is one of the metrics that the hospitals really look at for quality. So we have then looked at the flexible housing pool as the way to address how people experiencing homelessness move through these high costs institutional settings and how we can stop this cycle. So we may see people in emergency rooms, then from their cycle to might go discharge, leave the emergency room and go into an encampment or living on the street. They may come back into the hospital and get admitted, then have an inpatient stay. From there would be discharged to a publicly funded shelter. Maybe the shelter, they may have a psychological or need psychiatric care, and then from be admitted to a psychiatric hospital. At some folks then may, upon discharge from the psychiatric hospital, have a jail encounter. It just kind of keeps going around and around in this cycle. And so how can we use housing as an intervention to stop this, this cycle and be able to help a person with their improving in quality of life? So the flexible housing pool is based on a permanent supportive housing program that was modeled out of Los Angeles County, where they, again, successfully housed over 3,000 people in supportive housing. They saw that for the participants that they housed, about 68% reduction in emergency room visits, a 77% reduction in inpatient days, and a 60% reduction in mental health crisis stabilization services. So our goal is to do the same in our flexible housing pool, where we connect people to supportive housing, connect them to the resources that they need, and then also look at how we are able to change the way in which service delivery exists, and to apply what we understand as a promising practice around how to best coordinate with healthcare. So our vision is really looking at investors not from across the health systems to invest in housing as a solution, and really to be able to increase the amount of supportive housing for people with complex health needs that also have justice involvement. So our intervention, I've been talking about supportive housing, is one in which a person receives tenancy supports, which we'll talk about in detail, care coordination through their insurance provider that connects them to clinical care, and then affordable subsidized housing, where a person would pay up to no more than 30% of their income towards rent, and that would be their supportive housing. Make up the components of the model. Supportive housing, again, is a SAMHSA evidence-based model. I think that what we are bringing to this, in addition to this coordination that's innovative, is also bringing the care coordination as a concrete piece of the model. So in order for someone to be eligible for the flexible housing pool, they need to be literally homeless, meaning living on the streets or in a place not meant for human habitation, or living in a shelter, or to be unstably housed, bouncing around from different and living in different, doubled up with other family members, but on a temporary basis. That a person does not require a diagnosed disability in order to enter the program, which is true for other permanent supportive housing programs that are provided by the U.S. Department of Housing and Urban Development, or require chronic homelessness, which means that they have to be homeless for a year and have a diagnosed disability, which other permanent supportive housing programs funded by HUD require. But it does require that someone is a frequent or persistent utilizer of services as defined by the person who is paying, by the entity that is paying for the housing. And that's who we call investors. So who we target for the housing intervention really depends upon the investor themselves. And so for the city of Chicago, as the first and who provided the seed funding for the pool, the person needs to be a persistent utilizer of the homeless system and a persistent utilizer of the Cook County Health System, meaning that they need to have be here between our emergency department and with our jail health services. So we operate within the flexible housing pool a housing first, which you may have heard Housing First mentioned before. Housing First really looks at being able to accept anyone into a program, and that we don't exclude people because of certain conditions. So if someone is actively using drugs and alcohol, they are not excluded. If they have someone is actively using or in relapse or in recovery and relapses, they don't get excluded. We don't exclude people based on their criminal legal background. People who are on the sex offender registry are also able to participate in the program. There's no that's not part of entry criteria. It doesn't matter what a person's family size or composition makes, that we serve the entire family, and that a household doesn't need to be taking medications, and that their housing is tied to medication adherence. A way in which a person could be evicted by a program by within the program is if they're evicted from their unit because they haven't followed the terms of their lease, but we will still stay with that with that person. They won't get kicked out of the program because they've been evicted from their unit. That their housing case managers and others will work with the person to be able to help support them as they continue on and try to find another apartment. So people pay about 30% of their income towards rent. If they don't have an income and there's zero income, they don't pay any rent, that it's all covered by the pool. That the housing specialists do try to find units where utilities are included, and then the pool also pays for security deposits, furniture, moving costs, and a welcome kit. So in the beginning, I talked about that part of the model includes tenancy supports. And what tenancy supports are services available to a person. So every person is assigned to a tenancy support case manager. And in that, the case manager will assist a person in trying to identify, and the team assist people to find apartments in the community. So they have choice about where a person might want to live in community, and they can choose to live anywhere in Cook County. They provide coaching and support around maintaining your relationship with your landlord and understanding terms of a lease. There's some soft skills around maintaining a budget, paying rent on time, other pieces around maintaining the household. The housing tenancy supports case manager will also support on identifying what are the goals that the person has while they're in the program, outside of now that a person is safe and stable in their own apartment. What are the opportunity? What are they looking to do? So if it's getting connected with employment, education, and learning about job opportunities, interviewing, working on resumes, and then they also assist them with accessing mainstream benefits, such as applying for link food assistance. If a person is disabled or is assumed to be disabled but doesn't have social security disability income, that they're able to help them through that process. So really understanding what are the mainstream benefits if they so that's the tenancy support. On the care coordination side, it's if a person doesn't have insurance, how to apply for insurance and getting them connected to health insurance, connecting with a primary care provider. If someone needs specialty care, such as if they have diabetes or some other chronic health condition, they are able to get connected to a specialty care provider. If someone has a mental health or substance use disorder and wants to get connected to community community mental health or substance use providers, that connection can be made. So those are the types of supports that are provided. I'm actually going to hand it over to you, Julie, to take over.
Great, thanks, Christine. So I'm going to talk through some of our stakeholders and then a little bit more in detail of how the flexible housing pool actually works. So we won't spend a ton of time on the stakeholders, but wanted to highlight broader categories. So the role for CSH is collaboration management and project management and working kind of on the planning side of things. And absolutely want to highlight the Center for Housing and Health as the housing coordination agency for the flexible housing pool. So the center's role is to really operationalize and implement the flexible housing pool itself. For the rest of the stakeholder partners, then you can see we have government involved, the homeless management information systems for the city of Chicago, as well as the suburban Cook County region, the foundation community. We have strong supporters in the foundation community as well, and health sector is absolutely engaged in the flexible housing pool. And also wanted to highlight when we're thinking about government partners, again, that's a very active and engaged collaboration between Cook County Health, the City of Chicago, as well as the housing authorities for each have been involved in the flexible housing pool. And so it's a really great example of a highly effective partnership and collaborations across regional units of government. So moving to the next slide, we'll talk again just a little bit more about how the flexible housing pool actually works. And I think Christine had to step away for just a moment. I don't know that I can take over. Oh, thanks, Christine. Sorry about that. So for how the FHP functions, we'll talk through the financing side and then how it works in reality for if I'm the tenant. So for the subsidies and tenancy supports, you can see kind of on the left hand of your screen. The hospitals, managed care organizations, the city and the county, as well as foundations, are considered the investors. They're the funders. So each one of these entities that's contributing funds, it actually goes into a shared pool. The resources from that shared pool of funding are then drawn down by the Center for Housing and Health. Because again, as the housing coordination agency, they're really coordinating all aspects of the supportive housing implementation from there. So they're identifying landlords, they're paying those rents and providing that subsidy for tenants. They're providing outreach and engagement for individuals who've been identified for the flexible housing pool. And then they're also making sure that everyone who's a tenant in the flexible housing pool has those tenancy support services provided, which Christine talked about earlier in what that actually means. But again, those tenancy sustaining services that really support each tenant in learning tenancy skills and having a long-term successful tenancy. On the clinical service side, then the healthcare partners like Cook County Health are responsible for, again, ensuring those clinical needs are met. And so if you think back to one of Christine's earlier slides, talking about the social determinants of health and, really the relatively small proportion of impact that the clinical services have in our overall health, that's again where our healthcare partners have a huge role, is ensuring that continuity of care or actually getting connected to clinical services for the first time, ensuring connections to care coordination, and that all of those clinical needs are being met for folks while they're in supportive housing, and even initiating that, while they're in the housing location stage of the flexible housing pool. So then moving on to the next slide, we will talk about, again, a little bit more detail of the financial flow for the flexible housing pool. Again, this is actually probably one of the most unique parts of this model, is recognizing how the financing works. So because this is not utilizing any funding from HUD that Christine talked about earlier, and none of the typical sources that are used to fund for supportive housing, it provides a lot more freedom as well, so that the investors can really determine the parameters of who's eligible, parameters for eligibility, all of those pieces. So for the financial flow, again, you can see that the City of Chicago, and there are multiple agencies, so including Department of Family and Support Services, Department of Housing, have contributed to the flexible housing pool. Chicago Housing Authority, the county agencies, so Cook County Health and CountyCare have contributed funds. Hospitals have contributed funds. Health plans have contributed funds. Really in leadership from CountyCare as being the first, Medicaid managed care organization that contributed funds to the flexible housing pool. And then foundations will also be able to contribute. The funds are then held in an escrow account that the City of Chicago manages. And again, those funds are actually drawn down by the Center for Housing and Health. This structure also really eliminates a lot of the traditional challenges and structures for some of the more typical contractual relationships. And historically, with other projects, there might be like one-off financial contracts between each one of these partners. And so this is a really great way to kind of consolidate and increase efficiency across all of these partners as well, because again, it's held in one fund, and the center is drawing down those funds with typically like one reporting structure, a simplified invoicing structure, again, because it's all streamlined through this one process. And then the center has oversight of ensuring that the landlords are paid on time for those subsidies. They're ensuring that their partners who participate in providing those tenancy supports, that those services are maintained and that they have all the subcontractors that they need to ensure that those services are provided. So moving on to the next slide, we just kind of wanted to highlight where the fund is at today. So you can see the funding commitments have really increased over the last couple of years, so that at this point, in total, we have about $23 million that's been committed to the flexible housing pool to date. We continue to do engagements and talking with healthcare providers, but it's really scaled over time, and we're working to kind of really just continue scaling that so that, again, more of our neighbors around the Chicago and Cook County region can get housed and have supportive housing and have that stability so that everyone in the community, can move forward in their lives. Christine also asked me to talk a little bit more about governance as well. So again, with a collaboration like this, there is certainly an oversight and governance structure. So with our governance council, and they function kind of like how you might think of a board functioning. They are the ultimate decision-making body, and they have ultimate oversight. The governance council is made up of two groups, investors, and that could be investors from a variety of stakeholder groups, as well as folks with lived expertise. And actually, we are in the process of increasing the lived expertise governance seats to 40% of the overall body. It's a relatively, again, small governance group. However, the governance recently implemented a new structure to ensure that as we have additional investors added to the flexible housing pool, the seats reserved for people with lived expertise will also continue to increase, which really preserves, their voting power and their decision-making around that table. When the governance council meets, there's also advisory members around the table. So non-voting individuals, but who maybe have particular expertise or who are a part of the stakeholder groups, like our continuums of care, the HMIS providers, folks from CSH. We would all be considered advisory members around that table and absolutely are not voting members in any way. But that's kind of the high-level picture of how that ultimate governance functions. So underneath the governance, there's kind of these additional layers to operationalize. Again, like any collaboration or any organization, there's the oversight, and then there's the work that happens to operationalize. So the Lived Experience Advisory Committee includes folks with lived expertise of homelessness, as well as folks who have lived expertise within the flexible housing pool, so flexible housing pool tenants. The reason why there are non-FHP tenants in the Lived Experience Advisory Committee is because we actually started recruiting before there were ever tenants in the flexible housing pool, because we really valued that expertise and knew that that was necessary. for operationalizing the project and really implementing. So from there, we have the Flexible Housing Pool leadership team, which includes operational leads from all of the key partners. So the Center for Housing and Health, Cook County Health, the city, as well as UI Health, the Illinois Public Health Institute, are all really active partners kind of at this leadership team level to really guide implementation, understand what's happening programmatically and from a performance management perspective, as well as guiding and making recommendations to the Governance Council. They review data and performance metrics monthly, as well as, again, talking about kind of on-the-ground operational issues that might have come up. They also review the evaluation, which is being performed by the Collaborative Research Unit at Cook County Health. And then under that kind of leadership group, there's a number of work groups as well that are really topic specific. So we have the racial equity work group. Again, Christine talked about the enormous disparities that we see in our region, and particularly in the city of Chicago. And the Flexible Housing Pool wanted to ensure that ensure that we're looking at racial equity kind of throughout this project and process, and that there's a specific group of folks that are constantly looking specifically to ensure, looking at operational data, asking questions, thinking about how we can connect to broader efforts in the community as well as we're working to address racial inequities in our communities. There's also an evaluation work group. There's a sustainability work group, and that work group in particular is looking at the long-term financing and sustainability for the flexible housing pool. Recognize, again, housing is a lifetime need, right? And that for folks who are being served by the flexible housing pool, these are long-term subsidy needs. We then have a work group that's focused on engaging with our healthcare partners, as well as recruiting for new healthcare partners around the table. And then finally, there's the system integration team. And that is really partnership between the Center for Housing and Health and the clinical and care coordination providers to ensure that there's effective on-the-ground communication and coordination for those tenants who are in the flexible housing pool between those systems. So moving on to the next slide, Christine also wanted me to talk a little bit more about the Lived Experience Advisory Committee. And so that group, we meet monthly. I actually staff their committee. And so their agendas are really crafted across a number of partners. First and foremost, things that they're interested, in the performance and dashboard review. Questions come up there that the group wants to talk more about. The center will also bring agenda items to their table for advice and guidance when it comes to so things like review and test a satisfaction day for budgeting. The group has also really been championing the role of peer leadership and paid peer roles within the flexible housing pool. That has been on their agenda, and we've been working towards peer mentorship opportunities for flexible housing pool tenants, volunteer as well as paid. Both roles are really of interest to the Lived Experience Advisory Committee, and so in response to that, the center has been working on what that can look like and what implementation can look like there. Other pieces, Cook County Health also informs those agendas so that as there might be questions related to care coordination or clinical needs, again, this whole entire group really works collaboratively on their ongoing agendas. And moving on to the next slide. Then we'll just kind of come to a close and come back together to talk about the participation parameters for flexible housing pool partners. And I think Christine touched on this a bit earlier, But again, just to kind of recenter on new healthcare partners that are coming around the table, every partner can choose to participate in the independent evaluation. It actually is already underway. They there are great reasons for that why I would want to, and there are reasons for why it might not work out in their particular situation. So really, they have the flexibility to determine if they want to participate or not. Again, every healthcare partner must ensure that every tenant has all appropriate and needed clinical care referrals to ensure that each tenant has the supports that they need to thrive and to meet their own health goals and to gain stability. The Center for Housing and Health is absolutely responsible for the tenancy as well as the tenancy supports, but they're not a clinical provider. And so to make sure that those lanes are really clear, we want to make sure healthcare partners are doing what they do best, and that the Center for Housing and Health is able to do what they do best, so that every tenant has access to kind of this range of services and supports so that they have what they need to meet their goals. Again, healthcare partners can really determine who they want to refer as long as they meet kind of the larger eligibility criteria that Christine talked about previously. And the contribution amount is $25,000 per person per year. Again, this fund is funding all things related to services, administration, outreach, as well as subsidies. And so that is kind of the financial modeling that we have done to ensure that folks have access to the resources that they need, to the stability that they need to have, so that everyone who's in the FHP really has that foundation of housing, so that they can move forward and do anything in life that they want to do, so that they have that stability of that home base moving forward. So I think with that, if there's anything Christina wanted to come back and add, otherwise we can also turn it back over to the team at Curl and everyone for questions.
Yeah, I don't have anything. I think that we were hoping to then, engage in discussion with you. Any questions you might have or other thoughts about the pool.
Yeah, thank you both. This was really informative. I know the program fairly well, and yet I learned some new things, particularly helpful things as we can think about our own partnership. So thank you both. And just so everybody understands, Christine wasn't just taking a random call from a family member or her stockbroker or anything like that. She had let us all know in our pre-meeting that she's actually working at the same time. And so she got called away to take care of some immediate work. So thank you, Julie and Christine, for doing a wonderful tag team addition. Much appreciated. Questions? Emily, I see that you have, Emily Jones, I see you have a question. Do you want to unmute and take it away?
Sure. Hi, I'm Emily. I'm a graduate fellow here at Curl, as well as a Master's of Social Work student. So I was just wondering, I noticed on one of the slides that 10 million of the funds were dedicated to youth experiencing homelessness. So I was just wondering if you could speak a little bit more about like some of the services and like how that partnership kind of works in a youth focused setting. So yeah, that's my question.
Can you take that, Julie?
Sure, happy to. So the City of Chicago Department of Housing made a contribution of 10 million specifically to focus on the needs of youth. And by youth, they're defining as 18 to 24. And so again, the folks identified for that cohort have been identified through the partnership and the data match that Christine talked about with Cook County Health. When it comes to youth, the city was interested in a couple specific things. So with typical programs funded by HUD for youth experiencing homelessness, a lot of them have been, there are time limitations, and with the structures and parameters of those youth-centered programs, the city is actually really interested in learning what is actually needed for long-term success without having to worry about time limitations. Because with youth, there are I think a range of needs and supports, which could include education, job supports, helping people find work, and the support. So there's added supports for employment as a part of the youth cohorts. And the city also really is very interested in learning, without these time limitations, to be able to understand more broadly about how many youth or what percentage of youth experiencing homelessness might need long-term supportive housing, about how many youth or what percentage of youth really need long-term affordable housing, and what youth might be exiting to stability and paying the rent fully on their own, and in about how long that might happen. So really using this as an opportunity to reach or to increase the reach of serving youth who are experiencing homelessness, supporting youth and stopping that cycle, and helping youth have access to the resources that they and their families might need, because about half of the households served by this youth expansion are families. And so using this opportunity to really have much better information to also inform that systems change. And a lot of these goals were created in collaboration with youth who are experiencing homelessness, providers who are serving youth already in the city. And so it's been a very iterative process, and really the city took this as an opportunity to really invest and learn about solutions, like true long-term solutions for youth experiencing homelessness.
Thank you. I see that Monica, there you are, Monica. I couldn't see your name on there. Sorry. Monica, do you want to unmute and give voice to your question?
Sure. I'm Monica Dolan. I'm the director of the Loyola Community Nursing Center. And because of the pandemic, just have noticed an uptick of folks that, have not been redetermined with Medicaid, have lost connections to all kinds of service providers. So I'm just wondering, as we're finding these folks, and many of these folks are found through community organizations, if there is an access point for, just the regular community groups or organizations to start referring some of these folks, because under like the Housing First framework, usually, the housing piece does actually, it comes first, and then we address other, some of these other things that happen through like disorganized thinking or getting lost in systems. We kind of address those second. So I'm just wondering how that would work.
Yeah, so I can take that, and then Christine can add in, because I know she's also having to multitask a bit. So there isn't a referral avenue for other community partners. The referrals really are identified via data match, and it's also part of larger evaluation and research. And the referrals really are generated by data matches. So in my work in a community organization, folks that I meet, I can't refer, right? Like it really is a referral that's generated only through this data match process. Or alternatively, for like a hospital that has invested in the flexible housing pool, again, they would have their own, referral or data matching process to identify individuals. There isn't, and this question actually comes up most often with our Lived Experience Advisory Committee, because every week that group is so incredibly passionate about ensuring that no one else experiences what they've been through. And that comes up frequently, right? With our community partners, as well as tenants, and it's structured really so that it's through these data matches is the referral pathway.
Thanks, Julie. Carol, do you want to unmute and ask your question?
Sure. So I know that there have been initiatives in a lot of the different wards, other parts of the cities, that are requiring a certain number of affordable units in new constructions and other requirements. Is the fact that we don't have enough safe, affordable housing, do you see that improving? I know that's contributing to many of the issues that you deal with on a daily basis, but are initiatives to create more affordable housing making an impact?
I guess I can share my perspective. I mean, the resources, I think everyone is probably, and by everyone I mean across the city and in the housing sector, the resources that are being put in are not matching a pace to end homelessness in our city or in most communities in our state. So right, like just structurally, there's an imbalance there. Are we making progress? I also think we'll see with the long-term impacts of COVID. You know, I think that the data is not there. We've also, you know, with the eviction moratoriums, but I think there's very good reason to be highly concerned, right? And there are resources being added, but do I think, you know, me, Julie, do I think those resources are adequate? And I don't think I am alone in this. You know, they're not going to meet all of our affordable or supportive housing needs in our city. From my perspective, that takes a much larger commitment, and also considering system rebalancing about how we're choosing to utilize resources, you know, as a community, as a city, statewide, federally. Like, it requires a much different approach if we actually are interested in ensuring that everyone has the right to housing in this country.
Mm-hmm. So with the CARES Act dollars that came through, there's funding for an additional 2,500 units of rapid rehousing, which is a 2-year program in which people experiencing homelessness are able to move into an apartment and that their rent is subsidized for a period of time, with the intent that over that year long, you know, it's up to 2 years. In Chicago, it's more like 9 months of service that people are provided, 9 months, and then it goes up to a year, and then people can keep extending for more. But the intent is that people have income to be able to take over the payment of their unit at the end of that 2-year, at the end of that period. And so there's a lot of factors in determining whether or not someone will have enough income to, you know, be able to afford market rate unit at the end of that period. But that's that short-term assistance is what was provided under CARES Act dollars to serve about 2,500 people. I share an office sometimes, so sometimes I'll put my mask on and off, just FYI. So I think that we will. I think that we are, I think that there's, but it isn't permanent housing, right? That through CARES Act dollars, that there weren't permanent housing dollars that were attached necessarily for targeted to homelessness, and that. So I think that's one thing that we understand, but we don't understand, as Julie said, how many people may become homeless once the eviction moratoria are lifted.
Thank you both. Emily Jones, your clarifying question.
Yes, so you were talking about the data match system, and I just wanted to clarify if that was the HMIS system. Mm-hmm. Okay, yeah, so just for like some background, I work at a youth homeless shelter in the city for my internship. So I've been working with the HMIS system and stuff. So I was just curious. Thank you.
Yeah, so we did a data match with both. So the Homeless Management Information System is the database that's used for tracking and identifying people experiencing homelessness. There's communities across the country are mandated to have a homeless management information system, an HMIS system, but the type of system or what data platform is used varies. So within Cook County, we have 2 different HMIS systems. We have one in the city of Chicago and then another in suburban Cook. So for the purposes of the flexible housing pool, we did a data match with both the Chicago HMIS system and the suburban Cook HMIS system.
Thanks, Christine. And speaking of Christine George, my colleague at Curl, has a question, and I can tell she's very passionate about the question because there are 4 question marks at the end of it. Take it away, Christine George.
You're on mute, Christine. We can't hear you. You're on mute.
You're on mute, Christine.
The question mark showed confusion, not to mention not being muted. My muted showed my confusion as well. But anyway, so before you had answered, I put my question before you had answered Emily's question, which, so I thought the data match was somehow with who were the patients at county or at the different places, and that's how you found it. Because what I was curious about was, does the data match system allow for a larger breadth of individuals to be to possibly be eligible or to be accessed than if you merely if you went through individual agencies? Yeah.
So the data match is between, it was with the HMIS systems and then the Cook County Health record, right? So you had to be a patient of Cook County Health. And we, so for our investment, our $5 million investment, we decided to choose to also to do that data match with HMIS to be able to identify who were either health plan members. So if you had CountyCare, and then also with, you know, with HMI, and that crossover between CountyCare and the HMIS system. But it's really driven by the investor and how they are identifying their population. So if Loyola University health centers, you know, medical centers were to invest in the flexible housing pool, they would be able to determine, will they do a data match with HMIS, or would they choose not to and identify another way to identify their frequent or persistent utilizers. So what the commitment is that you're using data to identify who is the population being served, because within healthcare, we are very accustomed to, we need to serve the person who's in front of us. So who comes into my ER or who comes into my program, they're homeless, so I want to refer them to that program. The shift has been around, how are we identifying people who have experienced homelessness over periods of time, and who have persistent utilization and persistent costs over periods of time, not necessarily the person who's right in front of me right now. So that definition of persistent utilizer is really identified by the investor. And utilizing HMIS for also including people who are long-term shelter or street outreach is also a component of the city of Chicago and Cook County Health investments.
Thank you.
Great. Other questions that people want to unmute and throw out there?
Is persistent utilizer synonymous with being chronically homeless? So no. However, there is we find that many people may be chronically homeless who are in the pool. So that is our assumption. So there's a specific definition that HUD identifies for people who are experiencing chronic homelessness that has to do with the number of days that a person is experiencing homelessness. So either that they're homeless for a straight year, meaning living in a shelter or living in a place not meant for human habitation, like in a park or outside, plus having a disability. So there's documentation that when someone applies for a program that's funded by HUD for chronic homelessness, they either need to have the straight year or episodes of homelessness over a period of time of years to equal that year, plus a disability. For the flexible housing pool, you don't have to have that, those specific things. We're looking at having at least one shelter encounter every year over a 2-year period, and then also having also looking at how people are engaged with, health, using emergency room and other emergency hospital services. So so our persistent utilizers, we define them differently. However, we think that a number of the people who've been identified as persistent utilizers are also chronically homeless. But that is going to be part of the evaluation, is really understanding who within the population that we've identified are also persistent utilizers or are also chronically homeless.
Thank you. Other questions? I actually have one, and that is, just in general, can either of you speak to the complexity of sort of working with the city and the city resources and the county resources and the systems behind both of those? I ask because I know those are not always seamless, shall we say. And so I'm just kind of curious to sort of hear a bit about, not asking you to tell tales out of school exactly, but just kind of reflect on that a bit.
So, I mean, I think that part of this is that that at least for the pool, that the experience of someone being in the flexible housing pool is really their experience primarily, that they are first engaged by the Center for Housing and Health and the community-based agencies that they are working with. So the Center for Housing and Health partners on the adult side with Thresholds, with Deborah's Place, with Housing Forward, with Christian Community Health Center, and other agencies, so that the first encounter that a person has, most likely, if they're not referred directly from our emergency rooms, is with an outreach worker on the homeless end, and that the payer on the back, be that the county or the city or one of the advocate or UI Health or any of those investors, that the experience of the flexible housing pool should be the same, regardless of who that payer is. So so I think that the coordination that then happens, that we find, at least on the health system end, is that we are doing a lot of work on the health plan end and being able to connect someone to their care coordinator on the health side, who for most folks, they haven't had contact with a care coordinator. A lot of care management is phone based, and so in that, if people don't have a phone, or they're moving from bit, phone numbers change, or just aren't able to contact people, that the kind of the first, that a lot of this work has been around coordination between the housing case manager and then their care management, their care coordinator. So that messiness of care coordination and being able to connect the flexible housing pool provides that type of through the systems integration team meetings, and we have a coordinator for the flexible housing pool at Cook County Health, and then CountyCare also has a coordinator for the flexible housing pool just for CountyCare members. So we have full-time staff at the health system really dedicated to ensuring that there's coordination for participants in the pool. I don't know, what else would you add, Julie?
No, I mean, I think that's a really great answer. And I think a lot of the great collaboration also comes back to the early work to really align on goals and priorities, which I think is really important for this collaboration. Is that several years ago, Cook County Health and the city really did a lot of work to center on like program model, shared, goals, and centering on what Christine just talked about, of ensuring that, the tenant experience being seamless. And I think that actually has been a really strong foundation for all of these other moving parts that can be complicated, for the behind the scenes pieces.
Very good, thank you. Other questions from the gathered faithful? Christine, George, are you trying to unmute? It looks like you might have a question.
Yes. I just was too lazy to do the chat line. I'm wondering, looking now back at what you've been doing this for 18 months, 2 years, am I right?
We launched in March of 2019.
What have been the most difficult roadblocks, or, in terms of both reaching people and getting people into housing? And has it been uniform across the board, or are different populations really different?
Mm-hmm. So I think that some of the difficulties, so there's difficulties at all different parts of the process. So one part is just finding people, right? So we do have an alert system within our health record, so that when anyone who is eligible for the flexible housing pool checks into a Cook County Health facility, be that the jail or our emergency room or one of our clinics, we get a text message that says FHP alert. It's FHP alert. And so then either the emergency room social worker or someone will, or our FHP coordinators will go down and meet with the person. It used to be me when we first started 2 years ago, and I'd go down and meet with the participant and talk to them about the program, and then try and do a warm handoff to the outreach worker to be able to find the person. So I think that the outreach workers also do a lot in going to shelters, trying to going to encampments, trying to find people who may be eligible for the pool. So I think finding people who are eligible poses challenges. I think that once someone is found, and then it's the next phase of looking at the housing process. I think that there's different examples, right, of where even though we may have a housing first, we also, let me say, one of the strategies that we have is bridge housing. So if someone is, there are apartments that are available in the community that are master leased by the Center for Housing and Health. So if someone is particularly hard to find, or if they have chronic health conditions and are living on the street, that they are able to move into an apartment temporarily, and they stay there while they are looking for their longer term, their permanent apartment. And so in that, people may not have birth certificates, may not have driver's license, may have a background, maybe a sex offender. That there's that IDs and sex offense are two primary challenges that people have in being able to find apartments or find landlords who are willing to rent. I think that the other challenge is around connecting people to mental health treatment is a primary challenge in many ways. So one is that sometimes people may have mental health conditions and not themselves be aware of the fact that they have a mental health disorder or be interested in any type of support or treatment. And in that, or not be wanting to give, like I remember, participants who didn't want to complete, someone had a CHA voucher, but they were afraid to fill out the application to be able to provide that information and to be able to provide their ID. And, so that there's that pieces of experiencing active mental health symptoms that prevent moving forward with applications. Or there was another person who just had a lot of challenges around just in physical appearance and changing clothes and wearing clothes. So they had difficulty in getting him to a point where they were able to take him to a landlord and get into an apartment, right? Like that was just part of the difficulty in that, in those gaps. So it's like, I think that what I see as the largest kind of gap that we're trying to work towards is for people who we say, okay, there's community-based mental health. People are able to get an appointment to go see a counselor, but we have this group of folks who that isn't going to be a reality where they're able to get to an appointment or want to go to an appointment. And that's also not a requirement that people are, need to have medication and or compliance with medical treatment plans, right? That this is, everyone has a right to housing, right? Regardless of all of these extra with these other pieces. So I think that for me, it's the mental health access for people with active mental health systems has been the hardest piece around connection. Julie, what would you say?
Yeah, I think those, and even I think it's like even an earlier challenge too is just the coordination between various, systems too, like between the tenancy support providers and, so the staff on the ground and care coordinators, and finding out who's the right person, for a wide variety of health plans, to then make sure that folks are getting access to all the range of healthcare needs they might have. And then systems wise, I think, there's always a challenge around data sharing and data sharing agreements. And, I wouldn't do a deep dive into that, but I think that's just any cross-sector partnerships, that is always going to be a challenge. And previously there were some challenges with unit acquisition, and actually through some partnership that has really, there's been a lot of work in that area, but certainly I think in the first 2 years of the project, just even unit acquisition throughout the city and getting kind of the volume or some previous pain points too.
Yeah, that all makes sense. What both of you reported, and Julie, of course, the collaborative element rings true for us at Curl, right? It's what we need to do. It's how we need to do it. It also complicates and both in helpful and unhelpful or sometimes frustrating ways. So I can only imagine when I think back on the slides that you had, all the partners, all the systems that are behind all the partners. My mother would say that's more than a notion. Other questions before we wrap up here? All right. Well, I want to thank you both for taking time out of your busy days and joining us on Friday morning. It was really very helpful, very informative, and we wish you all the best.
Yes, thank you so much for inviting us and for caring about this as a topic. So we're very happy to share, and thank you so much for the invitation.
Yeah.
Have a good week.
Have a good week, everybody, and join us again next week if you're able.
Thank you.
Bye.
Thank
you.